Okay, well, thank you. Thanks, everybody. Thanks to the organizers for inviting me here today. It's very much an honor. I have been to Johns Hopkins once before, but it was in a much older building than this. And so it's nice to see the new facilities. I think I was here, not in this building, 15 years ago. Very nice old library somewhere. And it's very nice to be on this panel. There are some close colleagues here today. Kim and I worked together for many years at CDC. Dr. Chizema, who will follow me, is someone we worked with very closely in the Zambia National Malaria Elimination Program. And Brian and I have sat together in about 2,000 meetings at WHO. So lots of connectivity there. So I'm just going to give a few thoughts on malaria elimination in Africa, some of the key challenges that we're facing, but really more from the perspective of what we're working on at PATH. There are many, many speakers here today that are going to go into some of these areas in much more depth. And so I'm just going to touch on our activities from our PATH perspective, and then conclude with some concluding thoughts. So I wake up every day thinking about the Global Malaria Eradication Program. I'm sure you do too. And I just think it's good to just very briefly remind ourselves, what the assumptions were in that effort. And basically it relied on DDT and anti-malarial drug treatment, of course, with chloroquine, both individual patients and as mass treatment or chemoprevention, and then surveillance to detect and eliminate reservoirs. And these are still some of the similar tools that we have today, although fortunately we have others. So it's good for us to just remember where we've been, and that this, of course, was generally regarded as a failure, but did result in elimination of malaria in 37 countries over several decades. And the interest in elimination now, of course, has prompted a lot of re-examination of the reasons for the failure of the GMEP. And there are some of the same kinds of issues that we're dealing with today and that we'll hear more about today, including insecticide resistance, program management issues, a lack of research or funding of research, community engagement issues, and of course, sufficient funding. And of course, most prominently for the GMEP, it did not really seriously include Africa in its activities. And this effort was suspended in 1969. So Kim has already talked about this, and I guess this is something that will happen during the day occasionally. So I'm not going to dwell on this. We've already heard about the high burden to high impact. That's the brochure cover that summarizes some of the strategic activities that Kim already went over. I do think it's worth, and I'm glad that Kim and I agree, that I don't think this effort is in conflict with our elimination goals, but we obviously do need to work through malaria, through the road to elimination is going to be through these highest burden countries. And I think this is really already pretty well encapsulated in the WHO strategic framework for malaria elimination, which is shown here. And I think Rick Steckedy is going to talk a little bit more about this later today. But this really points out that every country is striving towards that goal with a stepwise approach in terms of enhancing their core strategies, vector control and case management, getting their information systems sufficiently robust and sensitive to be able to do good surveillance, using other strategies to do population-wide parasite clearance or additional or new interventions. That might be a malaria vaccine, for example, and then case investigation and on the road to elimination. So I think that this is not a new concept in terms of addressing the high burden countries, but I think it's a bit of a refocusing. So let me just turn now to some of these key challenges and just say, for those of you that aren't familiar with PATH, we do a lot of things in global health and malaria. These are our strategic objectives, and it's really, we try to focus on developing and introducing and evaluating new tools and strategies, as well as optimizing the delivery of our current tools and approaches. We have a special focus on measurement and tools and information and metrics, strengthening data quality and data use, and then cultivating partnerships so that we can most appropriately support our country partners. So just now on a couple of the challenges that we're working on, insecticide resistance, of course, and Professor Ransom is going to talk about this in much more detail in an upcoming session, but we are obviously dealing with widespread resistance to insecticides across Africa, and also the issue of outdoor biting in terms of most of our key core interventions being focused on indoor biting. And we have had an opportunity at PATH to work across a variety of vector control issues, including a next generation IRS project, which looks to do program evaluations and evaluating impact and cost effectiveness of these next generation IRS compounds that are now becoming increasingly available. Similarly, this year we'll be rolling out a new nets scale-up evaluation, so looking at some of the newer PBO nets and the dual active ingredient nets, and again looking at impact and cost effectiveness. VectorLink is a partnership that we have with PMI, which helps to inform a data-driven approach to where and when to apply IRS. And Megan Luttrell here from PATH is in the audience, and she runs that for us. And then I'm going to say a few words about attractive targeted sugar baits, which could be a promising vector control tool, and we're working in that area as well. So again, just to say, there are a lot of potential vector control areas of inquiry. Some of the ones illustrated here, we'll have data in the next near term, probably in the next several years from the field, particularly thinking about housing improvements and insecticides like ivermectin and how they might be added to the toolkit. And then I'm going to talk a little bit now about attractive targeted sugar baits. So this is a picture of one on the right there hanging on a hut. It's a combination of an attractant, a sugar, and an oral toxin. And these had a really nice effect in early field studies on outdoor biting anophelines. In Mali, where the sort of early studies have been done, resulted in about a log reduction in transmission. That's through measured as entomologic inoculation rate. They didn't have much of an effect in that setting on non-target organisms, which is a concern, so bees and so forth, and they lasted about 6 months. They're pretty easily deployed, as you can see. It's about a notebook size structure that just can be easily handled and carried. And we are going to be evaluating this with some partners in some East African studies, starting, we hope, this year. It will be interesting because, of course, the sugar sources and the ecology are very different in for example, Zambia and Kenya, where we're going to be working as opposed to Mali. Another area where we've been involved is looking at the asymptomatic reservoir, as Kim has already touched on. In two areas we've worked on is the issue of more sensitive diagnostics. You do, of course, if you increase your diagnostic sensitivity, you can increase the detected proportion of the infectious reservoir, or at least the asymptomatic reservoir. How much of that is infectious is something that Professor Busima will be talking about later today. We worked with Alir to develop a highly sensitive RDT, which was launched a couple years ago now, about a year and a half ago, which has a sensitivity around 20 parasites per microliter, so about a log scale better than the current RDTs. But it has been a little bit difficult to determine what the best use case should be for this, and that's work that's really still ongoing. Does it have value in reactive case detection? Is it something that could be used in early pregnancy to better detect low-density infections in pregnant women? Should some of our mass or focal test and treat strategies be revisited with this? And it probably does depend on the setting and what the profile of the low-density infections looks like in any particular population, so it really needs to be examined in a variety of settings. The other area where we've been working is in the mass drug administration, so addressing this reservoir not through detection but through treatment. And this is work that's been pursued through our MASEPA project, which currently is focused in Zambia, Senegal, and Ethiopia, but this is about a 15-year-long project, has worked in a variety of partner countries. Rick Steckety, who you're going to hear from later, was a founding person for MASEPA, and basically this is an opportunity to partner with programs to evaluate and implement a package of interventions to reduce burden and eliminate malaria, and depending on the transmission setting. And these current countries encompass a broad array of transmission settings. So working with Dr. Chizema and her National Malaria Elimination Program colleagues, a community randomized controlled trial of MDA was conducted in Southern Province in Zambia. This is a 2-year trial, 2 rounds a year for 2 years, comparing MDA and focal MDA, in which just households that were RDT positive received the mass treatment. The drug was dihydroartemisinin and piperacin, and it was compared to a standard of care, which was no mass treatment in Southern Province. Pretty big study, 300,000 people, and stratified into higher and lower transmission strata, greater than 10% and then below. And it's important to note the standard of care was delivered throughout the study site, and it was quite high. It was very high vector control coverage with LNs and IRS, basically getting over 90% coverage with either or. Very good access to diagnosis and case management. I'll say a bit more about that, including community-based case management rolled out during the study. And to cut to the chase, this showed that MDA did lead to, not surprisingly, a marked reduction in parasite prevalence in both high and low transmission settings, but it was particularly beneficial in the low transmission settings, and it was beyond the effect of the core package. So you see there that parasite prevalence decreased by over 72% and incidence by 37%. Focal MDA wasn't as good, and in either case, transmission was not interrupted. This study and others that have been conducted over the last few years have contributed to some recent modification in WHO MDA recommendations, which do now consider the use of MDA in low transmission settings should there be adequate and effective other control measures in place. And just to say a bit more about the standard package that was delivered in the control areas. So these are not in the clusters that got MDA, but these are just in the clusters that got the vector control, high coverage with case management, and good surveillance. And you can see a pretty dramatic reduction in both the high transmission areas in red and the low transmission areas in blue without the MDA. This is it's encouraging in terms of the impact of the package of interventions. It also is possible that there was some mass effect from the MDA. I think there's some data now out of the greater Mekong where other MDA studies are being done to suggest that the mass effect could have a bit of a consideration in this as well. So the program has been rolling out MDA as part of their core package now, and we've been working with them to adapt it for programmatic use, so shorter campaigns, house-to-house distribution, micro-planning, and novel local solutions for transport. Again, it's delivered with good vector control that's implemented either during or prior, and good integrated community case management with a target of 1 CHW per 700 to 800 population. In the study area, there has been a good maintenance of low prevalence, less than 4% parasite prevalence, with a few focal outlier hotspot areas which we're trying to investigate a bit more. And then the routine treatment and surveillance strategy serves as the exit strategy. So MDA is not being continued. So just a few words now about case management coverage. The World Malaria Report highlights that this is an area where there's a lot of progress to be made. About 40% of children with fever are not brought for treatment overall. And we know that case management coverage can have an impact on transmission. It varies with the type of drug, its effect on gametocytes, and the transmission intensity of the setting. But for example, in the circled area there, That's a modeled estimate of what would happen with different levels of case management coverage in an area of about 10% prevalence. And you get with about 60% coverage, you can get about a 40% reduction in clinical case incidence. So this is an important strategy to pursue. And in Zambia, in earlier studies, we saw this was a big gap in terms of accessing case management, with about 50% of children not being brought for treatment. So there's been a clear commitment by the national program to expand access to treatment, care, to address challenges in staffing at rural health facilities. And this ongoing rollout of CHWs has been going on since 2011, providing case management and surveillance in their communities. And where appropriate, when the transmission setting allows, the community health workers also perform reactive case detection. So what happens when you increase your access through scaling up community health workers? Here's some modeling work that's out of Zambia, where we're plotting here the travel time to the nearest point of care for people. And on the left, that's with access to motorized transport, and on the right, walking. And you can see the addition of CHWs has really changed the distance that people need to go from over 20 kilometers to less than 5 kilometers. And the time to access treatment has been reduced to less than 1 hour for many people. And in Southern Province, we've been able to measure what this looks like in terms of increased access to treatment seeking, and it looks so far, even in the early phases of this rollout, that it resulted in a 10 to 15% increase in treatment seeking rates. And just to say that Zambia is committed to expanding this rollout nationwide, and these are the plans upcoming. And I should say Dr. Chizema knows more about Zambia than anyone here, and she may want to go into more detail on some of these points. In terms of reactive case detection in Zambia, as I mentioned, the CHWs do follow back patients to households when they can, when transmission is low enough to do so. And then those data are also collected and uploaded into the surveillance system, and then turned into information for action with dashboards and sharing across all levels of the health system. In Senegal, because reactive case detection was being done in a much lower transmission area where transmission had been lower longer, the screening of households was not felt to be efficient, and most additional cases were found simply within the household and not in surrounding households. So they've gone to focal drug administration without testing. And we're trying to look at these different strategies with different ways. They're not easy to measure impact because in general transmission is quite low in these areas, but we're trying to use serology to look at transmission reduction and parasite genomics as well for both transmission reduction, following chains of transmission, and looking how parasites are imported and flow across the country. And just a few words about what we're doing in surveillance, which has historically, of course, been a very difficult area for malaria, with traditionally very heavy reliance on cross-sectional surveys and not really being used for routine decision-making, not much in the way of feedback loops, and not much in the way of data quality checks, and being very hard systems to get information out of. And that has changed over the last 5, 6, 7 years in many places, with much better surveillance, use of better tools, including the ones you see listed there, phones, data visualization tools, and so forth, and better partnerships in developing these systems between the public and private sectors. And this is an approach that we've been working on in Zambia, Senegal, called Visualize No Malaria. And basically, this just shows one of the dashboards that is created out of this software package. It's not a software package, it's basically an approach to managing the data and delivering graphics that are useful and delivered and designed by the local malaria program. So on the left there you see a training and feedback session where these dashboards are tweaked and revised as people find them useful or not, and improved on a regular basis. And this just shows the technology that's being used currently. This is an approach where we try to take the best tools that we can find for data preparation, analysis, and visualization for users at all levels. And this includes data from a lot of different kinds of data environments, obviously epidemiology, but also entomology, population, commodity data, and so forth. And these tools are very good at handling these kinds of different kinds of data and putting them into a format that can be looked at in terms of visualizations for users to be able to use well. So another serious emphasis of this approach is really to invest in the ongoing training and support and modification of the tools so that the countries are building their own systems. This is not a ready-made sort of predetermined package that is dropped in. And then finally, just a couple of other places where we've been spending some time. Not going to probably talk about Plasmodium vivax very much today. It's only about 10% of the global burden in sub-Saharan Africa, but Ethiopia is a major vivax country. And we know that transmission is heavily driven by relapse. We've got some new tools now. We've been working with SD Biosensor on a point-of-care test for G6PD deficiency, which of course is an important thing to consider when you're giving primaquine or tafenoquine because of hemolytic anemia with those drugs in G6PD deficient people. And we're also looking at how to deploy these strategies in ways that make programmatic sense. And we're working with the teams in various countries, not only in Ethiopia, but in other parts of the world, to figure out those best deployment strategies. And then Dr. Moss has already mentioned RTSS, which PATH has been pretty heavily involved in over the decades. These pilots are going to give us sort of the definitive data on safety, impact, and feasibility. And as he mentioned, they began this week in Malawi, and that's the first baby vaccinated, baby one, as it's being affectionately called. This is an effort that's coordinated by WHO and supported by GSK and PATH. We know the vaccine is a modestly effective vaccine in the long term, although in models in higher transmission areas, the prevented morbidity and mortality can be considerable. But we also know that it has a higher efficacy in the short term, say in 6 months, and there is some thought to consider it for seasonal use in settings such as where SMC is delivered, so coupling it with that strategy. And Professor Greenwood is exploring that option. He may want to say a few words about that. So just in concluding, these are things that not PATH, but all of us need to be thinking about as we move forward on this. We need to continue to build the political will, the leadership, and of course the financial base to pursue this. And we need to, understand that the elimination space is quite crowded, and that there are well over a dozen diseases targeted for elimination. And so we need to make sure we understand that in the malaria world. We need to continue to collect evidence to inform models on how to accelerate to elimination by cost-effective prioritization and combining of interventions. And there was a recent paper on this from Winskill that begins to explore this, but clearly we need more information to do a better job of that. We need to streamline the evidence to policy to implementation process. We don't want RTSS to be the model for this, where it takes 30 years. Or even ITNs, which took a long time to get to the field. And so WHO has begun a revamp of their policy pipeline process, and hopefully that will be a joint effort that can get us to where we need to be a little bit quicker. And then last but certainly not least, we need to keep obviously investing in the people, skills, and training, not only in entomology, but in data and management and research. And so I conclude, usually I put up a public health hero like Bill Soper or somebody like that, but I found this fashion designer Cristobal Balenciaga, and as you can tell, I know nothing about fashion, but I thought his comment that elegance is elimination was appropriate for today. So thank you very much.
Thank you very much, Larry. Excellent. So, a couple of questions for Larry. Anybody? Yes.
So obviously,
Microphone. Sorry.
Make you work for it.
hey, so I'm Brian Greenhouse from UCSF. It was really interesting to see how you went from MDA to something that can be done by the control program, and I was just wondering what the process was to try to figure out how you can operationalize MDA in a way that was more, more feasible and more easy to scale.
Well, actually, I'm going to thank you. It's a good question, and I could wax eloquent, I'm sure. Well, maybe not that eloquent, but I think I'll let Elizabeth say a few words about that, because that's something that was largely led by her and her team. So it's a very smooth way of getting.
Do you want to say something now or in your talk?
How did you, the operationalization of the programmatic MDA and how that was developed? Yeah.
We come to it. Good. Well, I think we should move on.
Okay.
Thank you very much.
Thank you.